All right, welcome back to another episode here at Whiteboard Medicine. Today's topic is going to be kind of the culmination of a whole bunch of different topics mixed into one, and it's critical care inotropes, a comprehensive overview. So in this episode, we're going to dive into each one of these inotropes. We're going to be talking about their mechanism of action, indications, contraindications, clinical use, pharmacokinetics, duration of action, onset of action, clinical pearls, practice questions, hemodynamic effects, a whole bunch of stuff. It is going to be a long episode, so we're going to divide it by chapters, and you can skip around if you'd like. Chapter 1 is going to be Dobutamine, Chapter 2, Milrinone, Chapter 3, Epinephrine, Chapter 4, Levosimendan, and Chapter 5, Dopamine. This is a critical topic for anyone who works with these patients. Whether you're a trainee, a student, a physician, an MP, a PA, a nurse, an RT, what have you, anything in between, all these medications are really critical to have a good grasp on, a good understanding of. So hopefully you enjoy it. Hopefully you learn something from it. Let us know what you think. No further ado, let's dive into Chapter 1, Dobutamine. Let's dive into Dobutamine. Mechanism of action. How does Dobutamine work? Well, Dobutamine is a synthetic catecholamine, right? Catecholamines are things like norepinephrine, epinephrine, even phenylephrine are all different catecholamines. They act on catecholamine receptors. They're also sometimes called adrenergic. These are all somewhat synonyms, okay? Dobutamine in particular, though, focuses mostly on beta receptors, okay? Beta 1 adrenergic receptors. These receptors are in the heart tissue itself, right? And we have the heart, and they have these beta 1 receptors. Dobutamine stimulates those beta 1 receptors, and it increases myocardial contractility. It's a positive inotrope, positive inotropy. Inotrope being increasing contractility. It also somewhat increases heart rate. Heart rate increases are known as chronotropy. So inotropy is contractility. Chronotropy is heart rate. So beta 1 receptor agonism, stimulating beta 1 receptors in the heart, dobutamine increases myocardial contractility, also known as inotropy, and it increases heart rate, also known as chronotropy, although the primary effect is this increase on myocardial contractility. Dobutamine does have some slight beta 2 adrenergic effects. Beta 2 actually works on peripheral blood vessels. Let us mute our computer here, sorry. These peripheral blood vessels have all these smooth muscles coating the outside of them. And there's alpha 1 receptors in these. Alpha 1 receptors cause vasoconstriction, but there's also beta 2 receptors. And beta 2 receptors actually cause vasodilation. So dobutamine affects beta 1 receptors in the heart, increasing myocardial contractility, positive inotrope, and increasing heart rate, positive chronotrope. It also, though, stimulates beta 2 adrenergic receptors in the peripheral vasculature, which causes some mild vasodilation. This is why dobutamine can decrease blood pressure and cause hypotension sometimes. It gets confusing because there's some slight alpha 1 agonism. This is dose dependent, and typically the beta 2 effects are more. So although there is some slight alpha 1 agonism, which could cause vasoconstriction, the beta 2, wrote beta 1, the beta 2 effects on the peripheral vasculature are more. So there's usually more vasodilation. So dobutamine increases heart rate, increases contractility, and decreases blood pressure. When it comes to receptor sensitivity, there's some ratios here just to help you understand how much effect there is. And the ratio is 5 to 1 to 0.5, and that's for beta 1 to beta 2 to alpha 1. So there's 5 times as much beta 1 activity as beta 2 activity. And then there's 2 times as much beta 2 activity as alpha 1 activity, which is why you get contractility mostly from beta 1, increased heart rate from beta 1, some peripheral vasodilation from beta 2, and then alpha 1 is not really efficacious because it's such a small percent of effect that the beta 2 effect being higher causes vasodilation rather than the alpha 1 causing vasoconstriction. Hopefully that makes sense. It's a little confusing, so let us know if you have questions in the comments, but it's really about receptor selectivity and sensitivity, kind of that potency, and it most potently affects beta 1. Next potency affects beta 2, and then there's just a slight amount of effect on alpha 1. Stereochemistry, this is not that important unless you really want to go down the rabbit hole, but dobutamine is actually a racemic mixture. Racemic mixtures are outside the content of this video, but there's a negative and positive isomer. That's the racemic mixture. It's a mix of those two. And depending on the isomer, there's different potencies of effects on different receptors. So the positive isomer primarily affects beta 1 and beta 2 receptors, and then the negative isomer primarily affects alpha 1 receptors. And you can see negative isomer, alpha 1 agonist, weak beta 1 antagonist, right? So there's antagonist and agonist. Agonist means it stimulates the receptor, antagonist means it inhibits it. The positive isomer is a beta 1 and beta 2 agonist and alpha 1 antagonist. All this is confusing and probably not needed in terms of putting it in your brain. The thing to remember is that beta 1 receptor effect is more than beta 2 receptor effect, which is more than alpha 1 receptor effect. All right? And just know there's different isomers that kind of do different things within the mix of dobutamine. Dosing and titration. So in patients, the initial dose of dobutamine is usually 2 to 5 micrograms per kilogram per minute, with a common range being 2 to 15 micrograms per kilogram per minute. We don't tend to go above 15 micrograms per kilogram per minute, but you can. Some people do go up to 20. But if you were to see someone on 15, certainly 20 micrograms per kilogram per minute of dobutamine, that would be a really high dose. All right, it usually starts somewhere around 2. The onset of action is 1 to 2 minutes. It starts to act really quick. The duration of action is very short. The effect stops within about 10 minutes of discontinuation, so fast on, fast off. And then the metabolism, it is metabolized in the liver. It uses COMT to convert it to an inactive metabolite. And then those inactive metabolites are renally excreted. But the metabolites renally excreted are inactive. So renal function does not necessarily drive how much active dobutamine there is. Rather, these enzymes in the liver break dobutamine down into its inactive form that then is renally excreted. So dobutamine is fairly safe to use in patients with renal dysfunction because it's already kind of broken down into its inactive form before it has to be renally excreted. When you monitor dobutamine use and you titrate it, it's more complex than titrating something like norepinephrine in shock, right? Norepinephrine is something like septic shock. You're just titrating it to your MAP goal. Mostly that MAP goal is 65 millimeters of mercury, right? You haven't met that MAP goal. Every 2 to 5 minutes, you go up on the norepinephrine until you reach that MAP goal. But dobutamine is a lot harder because dobutamine is an inotrope. And what you're trying to do with dobutamine is you're trying to increase cardiac output, and by doing so, improve organ perfusion. Right? Because that's the whole goal. This is not to increase the blood pressure. The blood pressure actually usually drops while you're on dobutamine because of that beta 2 effect causing vasodilation. So the whole point of this is you're trying to increase cardiac output to increase organ perfusion. And to understand if you're doing that, you can trend a lot of different things, right? One of them is the mixed venous oxygen saturation, sometimes the lactate. Sometimes you look at CVP, MAP. There's also kind of advanced hemodynamics like thermodilutions and fix and all that kind of stuff. This is all outside the scope of this lecture, but the key is to know that titration of dobutamine is more complex than titration of something like norepinephrine because you're not going for blood pressure goals. It's not a vasopressor that you're using to increase the blood pressure. It's an inotrope. You're using it to improve your cardiac output with the goal being to improve organ perfusion. All right, hemodynamic effect summary. So what does dobutamine do to your hemodynamics? Well, we know that it does increase your heart rate, it increases your contractility, and by doing so, it increases your cardiac output. As we know, cardiac output equals stroke volume times heart rate. So if you're increasing the heart rate and you're increasing the stroke volume through an increase in contractility, you're going to be increasing your cardiac output. Your systemic vascular resistance, it often decreases. That is that beta 2 effect causing vasodilation. Your MAP, it can often decrease as well. Same thing, beta 2 effect causing peripheral vasodilation. So it can decrease your SVR and decrease your MAP. This is more advanced stuff, but your PA pressures can sometimes decrease. That's your pulmonary artery pressures from vasodilation. Your pulmonary capillary wedge pressure often decreases because you have improvement in forward flow, and your coronary perfusion, how well you're getting blood flow to your heart, often improves because it increased diastolic time and cardiac output. The caveat here, though, is that also dobutamine increases your myocardial oxygen demand because you're asking that heart muscle to squeeze more robustly. And when you ask it to squeeze more robustly, it consumes oxygen. So it needs more oxygen delivered to the myocardial tissue while you're on dobutamine, which dobutamine helps do, but where you fall in that balance is tough to say, right? Does the amount of contractility you're making that heart muscle do on dobutamine outpace the increase in blood flow you've triggered to the myocardial tissue? Tough to say. So sometimes you can get myocardial ischemia or worsening myocardial hypoxia. There's not enough oxygen being delivered for how much work you're making that myocardium do. But sometimes you're okay. Sometimes you're kind of balanced out in that regard. All right, indications for dobutamine. The biggest one is cardiogenic shock, right? It's first, second, third, fourth. We talk about it in different ways. Cardiogenic shock, low output heart failure, right ventricular failure, pulmonary hypertension. Now, sepsis-induced cardiomyopathy, sometimes abbreviated SICM, sometimes abbreviated SCCM, is this sepsis-induced myocardial dysfunction. These are patients who have sepsis who sometimes get depression of their contractility and myocardial function, leading to low cardiac output. And there's no good evidence to drive this, but sometimes an inotrope like dobutamine that may increase their cardiac output, even if they're in septic shock, may be helpful. Patients who are awaiting something like a left ventricular assist device or a transplant sometimes need an inotrope. Milrinone is commonly done at home. Sometimes dobutamine can be too. These are really sick patients, though, and this is, kind of outside of the specter of the critical care nature of this lecture. That's more kind of outpatient therapies. Sometimes you can give it for stress echocardiography to stress the heart, to try to diagnose a patient with some type of coronary ischemia. And then in patients who are vasodilatory, they're in distributive shock, you have to be really careful with this. So if a patient is septic, you don't just want to start them on dobutamine to increase their cardiac output, because this will actually decrease their blood pressure in their MAP. Most of these patients need norepinephrine to increase their MAP, and then if they have low cardiac output because they have something like sepsis-induced cardiomyopathy, you can sometimes give them dobutamine as an adjunct to try to increase that cardiac output. All right, contraindications and precautions. In patients with really bad hypertrophic obstructive cardiomyopathy or idiopathic hypertrophic subaortic stenosis, IHSS, these are conditions where you need as much filling time as possible. Okay, you don't want that heart squeezing too hard or too fast because they have this dynamic obstruction of their outflow tract. Again, this is complex. If this isn't registering, just ignore it. But for those kind of down the road who have a little bit more advanced knowledge of this, this is like dynamic outflow tract obstruction, where you want to be really careful with inotropes because putting the patient on an inotrope that's going to increase their heart rate and increase their contractility can sometimes worsen this outflow tract obstruction where you can't get blood to pump out of the left ventricle through the aortic outflow tract and out the aorta to the body. All right, and obviously if you have a known allergy, you don't want to use dobutamine. Use with caution. Patients with severe hypotension, use with caution because it will drop the blood pressure more. Patients with significant ventricular arrhythmias, you have to use with caution because of all the beta-1 effect. Beta-1 effects increase risk of tachydysrhythmias. All right, so using caution in them. Those with active myocardial ischemia, as we said, this can sometimes increase myocardial oxygen demand. So if you have someone with active myocardial ischemia, giving them dobutamine, you might have to, right? You might have to give it to them to help them survive, but it will worsen their myocardial ischemia because you're asking that muscle to work in overtime, and it increases that muscle's oxygen demand, and they might not always get enough blood flow to satisfy that oxygen demand. All right, and then persistent tachycardia and atrial arrhythmia, similar to ventricular arrhythmias that we talked about above. Adverse effects of dobutamine, as can be kind of surmised from what we were just talking about, dobutamine can cause tachyarrhythmias. It's through that beta-1 mediated effect that increases inotropy and chronotropy or heart rate. And this is one of the big barriers. Sometimes you have these really tough cases where patients in cardiogenic shock, they need an inotrope like dobutamine to increase their cardiac output to perfuse the rest of their bodies, but they're going in and out of ventricular arrhythmias. And the dobutamine is exactly exacerbating those arrhythmias, but you also need it. So sometimes you got to do antiarrhythmics like amiodarone or lidocaine or all these things to try to temporize and decrease the arrhythmias while continuing the dobutamine. Sometimes you need to dose reduce the dobutamine and kind of hit a happy medium. But this can be a really, really tough patient to manage. As we said, dobutamine has beta-2 receptor effects, which causes vasodilation, so it can cause hypotension, especially if someone's volume deplete or vasoplegic. It causes myocardial ischemia because it increases myocardial oxygen demand due to that beta effect. You can get tachyphylaxis, so over time, the beta receptors it acts on downregulate so that it's not as effective, and this usually is within 48 or 72 hours of a continuous infusion. So once you get to day 2 or 3 of being on dobutamine, you sometimes get lower effect from it because the heart downregulates all those beta receptors, and this is known as tachyphylaxis. So if you see a patient needing higher and higher doses after 2 to 3 days, sometimes it's just because they're not as responsive to it anymore. And then this is rare, but eosinophilic myocarditis. This is with prolonged dobutamine use. It's really only case reports, but if you get eosinophilia or high eosinophils and worsening cardiac function, sometimes it can be because this eosinophilic myocarditis, but this is really prolonged use. This is not something you're just going to see in a couple days in the ICU. There is a pharmacogenomic consideration, and this is just something we wanted to mention, is that some people have genetic polymorphisms in receptors responsible for beta effects, and as such, sometimes they will not respond to dobutamine the same way someone else will. So if you have someone with a really odd response to dobutamine, they might have one of these polymorphisms. They're not common. We don't test for them in the clinical arena very much. But if you're thinking about like inotropic therapy in the outpatient setting at home, sometimes this is good to know about. Dobutamine versus other inotropes. We have talked about all these inotropes in different videos, so check those out if you want to hear about them. But there's going to be dobutamine versus Milrinone versus epinephrine versus dopamine versus a medication called Levosimendan, which is actually not FDA approved in America, but it is approved in some other places. So mechanism of action, dobutamine is a catecholaminergic or adrenergic inotrope. Beta-1 effects are the most, causing increased contractility, followed by beta-2 effects, which cause vasodilation. Milrinone is a PDE3 inhibitor, phosphodiesterase 3 inhibitor, so it's non-catecholaminergic. Epinephrine is a vasopressor with alpha-1 effects, causing vasoconstriction, but it also has beta-1 and beta-2 effects too, so there is some inotropic. Dobutamine is not consistently used anymore. It sometimes is used for bradycardia, but not much, so we're going to just ignore that one. And then levosimendan is actually a calcium sensitizer, which is so interesting. It causes the myocardial cells to be more sensitive to calcium, and when they get that calcium, it causes the muscle to constrict. So it works different than the other two as well. Dobutamine has a rapid onset and short half-life. It's good for cardiogenic shock. Milrinone has less chronotropy, so it's less heart rate effective. It does not increase the heart rate much. And Milrinone is really nice for RV failure because it causes some more pulmonary vasodilation, which can offload that right ventricle. Epinephrine is good for vasopressor N inotrope. It causes increase in blood pressure and also increase in contractility. So just some of the differences there. If we get to the clinical pearls, you may prefer dobutamine over Milrinone, which is the other most common inotrope in heart failure with hypotension, since Milrinone actually causes more vasodilation and hypotension, although certainly dobutamine will cause hypotension. In septic shock with myocardial dysfunction, dobutamine can help augment cardiac output, especially if, especially after volume is optimized. So that's that sepsis-induced cardiomyopathy. Dobutamine can sometimes be a nice drug to increase the cardiac output. If you're using a balloon pump or Impella, dobutamine may synergize by unloading the ventricle while enhancing contractility. This is more advanced concept. Pulmonary artery catheters, also known as Swan-Ganz catheters, are helpful in titrating dobutamine. And then when you wean dobutamine, you usually reduce it by 1 to 2 micrograms per kilogram per minute every 30 to 60 minutes while monitoring those perfusion markers. All right, let's get into some practice questions. We haven't done this in a video before, or an episode if you're listening to this in podcast form. So we divided them up into a beginner question, an intermediate, and an advanced. And those watching this on YouTube, we think we just showed you the answer to the first one. Apologies. So the beginner question: what is the primary hemodynamic effect of dobutamine? A, decreases heart rate and blood pressure. B, increases contractility and cardiac output. C, causes profound vasoconstriction. Or D, increases preload by expanding volume. What is the primary hemodynamic effect of dobutamine? And we're just going to go straight into the answers. So if you want time to think, just pause the episode and think, and then restart it, because we're just going to dive right into the answers. So answer is B, increases contractility and cardiac output. All right, so dobutamine primarily stimulates beta-1 receptors, and beta-1 receptors work in the heart by increasing myocardial contractility, which increases the stroke volume and leads to an increase in cardiac output. It does not cause vasoconstriction. It does not volume expand. It actually causes vasodilation. So B is the correct answer, by increasing contractility and cardiac output. All right, into the intermediate level question. A 70-year-old patient with systolic heart failure with an ejection fraction of 25% is started on dobutamine for acute decompensated heart failure with cardiogenic shock. Over the next hour, her MAP drops from 72 to 63 millimeters of mercury despite improved urine output and increased cardiac index. What is the most likely explanation? A, dobutamine had a delayed onset of action. B, dobutamine causes vasodilation through beta-2 stimulation. C, dobutamine leads to increased afterload. And D, dobutamine worsens left ventricular function. Going right into the answer, so pause here if you want. The answer is B, dobutamine causes vasodilation through beta-1 stimulation. So dobutamine has some beta-2 agonist activity. Beta-2 affects the peripheral blood vessels and causes mild vasodilation, which can lead to a drop in systemic vascular resistance and MAP, especially in volume-depleted patients. Milrinone is even more robust in causing vasodilation, but dobutamine does too, right? So the correct answer is B, dobutamine causes vasodilation through beta-2 stimulation. And then last question is the advanced level. A 68-year-old man in cardiogenic shock is started on dobutamine at 5 micrograms per kilogram per minute. He is also receiving carvedilol for chronic heart failure with reduced ejection fraction. Despite escalating dobutamine doses, his cardiac index remains low. Which of the following best explains this blunted response? A, upregulation of PDE3 activity due to beta blockade. B, beta-2 receptor desensitization. C, competitive inhibition of beta-1 receptors by carvedilol. Or D, reflex vasoconstriction via alpha-1 stimulation. Going into the answer, so pause if you want. Answer is C, competitive inhibition at beta-1 receptors by carvedilol. So dobutamine works through beta-1 receptor agonism. And in patients on chronic beta blocker therapy, this can actually be blunted, especially patients on non-selective beta blockers like carvedilol. These block both beta-1 and beta-2 receptors and can lead to dobutamine having a more blunted response. No further ado, that was a mouthful. Let's dive into Milrinone. So Milrinone mechanism of action. Milrinone is a phosphodiesterase 3 inhibitor, a PDE3 inhibitor. And what this does, what this means, is when this enzyme, phosphodiesterase 3, is inhibited, it leads to an increase in intracellular cyclic adenosine monophosphate, or cAMP. And this happens in both cardiac myocytes as well as vascular smooth muscle. So we're already getting a little hint here that this is going to affect the heart with cardiac myocytes, and it's going to affect smooth muscle on the blood vessels. So it's not just going to have cardiac effects, but it'll have peripheral blood vessel effects too. In cardiac cells, inhibiting phosphodiesterase 3 and increasing cAMP in cardiac myocytes increases the amount of calcium that is influxing into the myocardial muscular heart cells. And this calcium causes positive inotropy, which is contractility. So it increases contractility. And then really interestingly, it also increases lusitropy, or relaxation. So not only does it cause the heart muscle cells to squeeze harder and increase contractility, also known as increased inotropy, it also then causes them to relax more afterwards, which increases lusitropy, or relaxation. In vascular smooth muscle cells, though, in the peripheral vasculature, this is a little different. So in these vascular smooth muscle cells, the increase in C-AMP from the inhibition of phosphodiesterase 3 actually causes vasodilation of arterial and venous beds. So it's an arterial vasodilator and a venous venodilator. All right, so it causes vasodilation, decreased systemic vascular resistance, and a lot of times this will decrease the mean arterial blood pressure, and we'll get into more of this. So it affects the cardiac cells different than the vascular smooth muscle cells. The net effects of this is increased in cardiac contractility or inotropy, increase in myocardial relaxation or lusitropy, decrease in cardiac afterload from arterial vasodilation, decrease in preload from venodilation, and then it decreases pulmonary vascular resistance or PVR. As one could imagine, for someone in cardiogenic shock, this is a gold mine. This is all the stuff you want, you know? You want increase in contractility. You want increase in relaxation. You want a decrease in afterload and a decrease in preload and a decrease in pulmonary vascular resistance. So these are all great changes for cardiogenic shock patients. Now in patients with mixed shock or septic shock, some of these changes can be a challenge, right? Because you will get a lot of hypotension with Milrinone. And if someone's in septic shock with sepsis-induced cardiomyopathy leading to a mixed septic and cardiogenic shock picture, the hypotension sometimes can be harder to deal with. Where someone in cardiogenic shock, a lot of these changes are really, really good, really nice for the management of cardiogenic shock. All right, dosing and pharmacokinetics of Milrinone. There is a loading dose of Milrinone you can do, but this is often skipped in the ICU. Obviously not medical advice, but in our practice, we don't tend to load Milrinone, so we're just going to cross this out. The maintenance dose of Milrinone is 0.0125 to 0.75 micrograms per kilogram per minute of a continuous infusion. The half-life is 2.5 to 4 hours, so it does stick around for a little, especially in those with renal impairment. This is really critical. This is one of those things in Milrinone that you need to know, and that the excretion of Milrinone, you're excreting the drug itself, not inactive metabolites. So if you have significant renal dysfunction, Milrinone is really unpredictable because you don't know how much is still circulating because you're not excreting it in your urine because of the renal dysfunction. So you get dose accumulation and renal dysfunction, which is one of those things you really need to think about. You got to be really cautious using Milrinone in those in renal dysfunction. Now you can, and there's some literature and evidence on this, and people have very mixed opinions. Some would suggest that it's totally fine. Others, though, would say you got to do it with a lot of caution or maybe not do it because you don't really know the dose that's accumulated over time in those with renal dysfunction. There's a dose reduction approach. So in those with renal dysfunction, consider starting 0.125 to 0.25 and titrate very carefully. So maybe stick at some smaller doses. Indications for Milrinone, as we already kind of mentioned above, acute decompensated heart failure, low cardiac output states, and right ventricular failure are all really nice indications for Milrinone. Patients on chronic beta blockers are sometimes less responsive to Dobutamine because Dobutamine affects beta 1 and beta 2 receptors. So those on chronic beta blockers, especially non-selective beta blockers like carvedilol, sometimes respond better to Milrinone because Milrinone is not affecting the beta receptors, whereas Dobutamine's mechanism of action is, so Dobutamine might be less effective. So cardiogenic shock or acute decompensated heart failure, especially those in chronic beta blockers, Milrinone is sometimes a really nice choice. Right ventricular failure, as we mentioned, Milrinone decreases the pulmonary vascular resistance, and the right ventricle pumps blood to the lungs. So that pulmonary vascular resistance is the right ventricular afterload. And if that pulmonary vascular resistance is decreased, that sometimes can help right ventricular ejection fraction because it's pumping against less resistance. So Milrinone can be a really nice choice for those with right ventricular failure or pulmonary hypertension because of that decrease in pulmonary vascular resistance you get. In the non-ICU setting, bridge to transplant VAD or decision, some patients go on home Milrinone to help them palliate as well, so you can be on home Milrinone too. And then often we prefer Milrinone over Dobutamine, as we mentioned, in patients on beta blockers or with right ventricular dysfunction. So those are two of the big populations where maybe consider grabbing for Milrinone first. Contraindications and precautions. Absolute contraindication, the only one is, known allergy to Milrinone. Relative contraindication or cautious use. Severe hypotension, because Milrinone will worsen the hypotension as an arterial and venodilator. Those with volume depletion, mostly because that'll just worsen hypotension. Arrhythmias, just like Dobutamine, Milrinone can increase the risk for arrhythmias. And then used with caution in those with renal failure, because Milrinone's active metabolites, active drug, I should say, is renally excreted. So you get a dose accumulation in those with renal failure. All right, adverse effects of Milrinone. Well, as we mentioned, it's an arterial and venous vasodilator, so you get hypotension. You also get ventricular arrhythmias, right? It increases myocardial contractility. Anything that increases myocardial contractility can increase incidence of ventricular arrhythmias. Same thing with atrial arrhythmias. It can increase risk of atrial arrhythmias. Milrinone rarely can cause thrombocytopenia and elevated liver enzymes. These are both self-limited and reversible, and they're uncommon. But if you have someone who's on Milrinone and you get worsening transaminitis that isn't well explained otherwise, or worsening thrombocytopenia, this can be from Milrinone. Now, more likely it's from something like hypoperfusion or shock or what have you, but just things to note. What's the hemodynamic effect of Milrinone? So heart rate is less effective by Milrinone than it is Dobutamine. So you might have a little bit of increase in heart rate, but not much. It does not have much chronotropic effect. You will get an increase in contractility. You will get a decrease in afterload, a decrease in pulmonary vascular resistance, a increase in cardiac output, a decrease in pulmonary capillary wedge pressure, and then a variable effect on coronary perfusion, mostly because the hypotension that can result. So we'll compare it to Dobutamine, but Dobutamine definitely increases heart rate more and may increase coronary perfusion a little bit more too, but tough to say for sure. All right, pharmacogenomics and tolerance. The big thing to note here is tachyphylaxis is uncommon compared to Dobutamine. So in our Dobutamine episode, which you can access in a bunch of the playlists below, critical care, pharmacotherapies, and then I think we'll probably make a vasopressor and inotrope playlist too, so all these will be in there too. But tachyphylaxis is when over time, in Dobutamine's case, about 2 to 3 days, your body downregulates the beta receptor, so then Dobutamine becomes less effective. And this is tachyphylaxis, so sometimes you see a need to start going up on Dobutamine after a couple days, not because the heart is sicker, but just because the Dobutamine is becoming less effective. They're getting tachyphylaxis. Milrinone doesn't tend to have as much tachyphylaxis, so the effect of Milrinone tends to be persistent and maintained. Milrinone does have a longer half-life, which means it's harder to wean off. It lingers more after stopping, so just something to be aware of. If we compare Milrinone to Dobutamine, which we've done a little bit already, but formally, the mechanism of action of Milrinone is PDE3 inhibition, phosphodiesterase 3, whereas Dobutamine is a catecholaminergic or adrenergic inotrope, so it affects beta 1 and beta 2 receptors. Milrinone has minimal effect on heart rate or chronotropy, whereas Dobutamine does increase heart rate and increase chronotropy. Milrinone has moderate to strong vasodilatory properties, whereas Dobutamine causes less vasodilation. Milrinone is highly effective even in those on beta blockers, whereas Dobutamine has a blunted response to those on beta blockers. Milrinone tends to come on and come off a little slower, whereas Dobutamine is very rapid on and off. Milrinone is cleared renally, Dobutamine is not. Both Milrinone and Dobutamine are effective in those with right ventricular failure, although Milrinone probably has a little bit more of a decrease in pulmonary vascular resistance. And then both of them can cause hypotension and arrhythmias, so you got to be careful with both of those just because of the increase in contractility. Some clinical pearls, then we'll get into practice questions. Consider skipping the bolus of Milrinone in ICU patients to avoid hypotension. Again, our practice pattern is not to bolus. Use caution in CKD, so chronic kidney disease or acute kidney disease, given the renal clearance can lead to accumulation and worsening arrhythmias. Can use in cardiac surgery and transplant patients. Can be used in combination with vasopressors, especially when there's hypotension that comes from it. So consider starting on norepinephrine if there's hypotension while you're starting your Milrinone. And it's got a longer half-life, so be cautious when weaning or switching inotropes because it's going to stick around a little bit longer than something like Dobutamine. So for practice questions, we divided up into one beginner, one medium, hard, I don't remember what we titled it, and then one advanced question or one more difficult question. We're going to read the potential answers, and then we'll go right into the actual answer. So if you want time to think about it, just pause the episode and ponder it, and then restart it when you're ready to hear the answer. And more of these practice questions on our Patreon page too. So beginner level. What is the primary therapeutic action of Milrinone in patients with heart failure? A, Milrinone decreases the heart rate. B, Milrinone increases blood volume. C, Milrinone increases cardiac contractility and causes vasodilation. Or D, Milrinone induces coronary vasospasm. All right, pause if you want. Going into the answer. The answer is C. Milrinone increases cardiac contractility and causes vasodilation. So as we talked about, Milrinone is a PDE3 inhibitor, a phosphodiesterase 3 inhibitor. This increases C-AMP levels, and it improves myocardial contractility, inotropy. It also causes lystropy, which is relaxation. But it also causes both venous and arterial vasodilation. So it increases cardiac contractility, but also causes vasodilation, or answer C. All right, on to the intermediate level question. Which of the following clinical scenarios would favor choosing Milrinone over Dobutamine? A, acute decompensated heart failure in a beta blocker naive patient. B, septic shock with a high cardiac output. C, cardiogenic shock in a patient on chronic carvedilol therapy. Or D, bradycardia due to sinus node dysfunction. Pause here and then we'll go into the answer if you'd like. The answer is C, cardiogenic shock in a patient on chronic carvedilol therapy. So Milrinone works independent of beta receptors, and as such it remains effective in patients on beta blockers like carvedilol. So if we go into the other answers, the answer was C. Answer A, acute decompensated heart failure in beta blocker naive patient. Dobutamine would be just fine, right? Because they're beta blocker naive, so their beta receptors would be happy to receive some Dobutamine or Milrinone for that answer. B, septic shock with high cardiac output. You wouldn't start an inotrope, either Milrinone or Dobutamine, in someone who had a high cardiac output, right? These are inotropes to try to increase a low cardiac output. We already talked about the answer C, and then D, bradycardia due to sinus node dysfunction. Dobutamine actually has more chronotropic effect, or it increases the heart rate more than Milrinone, so you would actually choose Dobutamine over Milrinone in someone bradycardic. All right, last question, which is advanced level. A 67-year-old patient with advanced systolic heart failure with an ejection fraction of 20%, as well as chronic kidney disease with a GFR of 25 milliliters per minute, is started on Milrinone, 0.5 micrograms per kilogram per minute for a low cardiac output shock state. 6 hours later, his MAP falls from 70 to 58 millimeters of mercury, and he develops frequent ventricular ectopy. What is the best next step? Increase the Milrinone to 0.75 micrograms per kilogram per minute. B, stop Milrinone and initiate norepinephrine. C, add a beta blocker to suppress the arrhythmia. Or D, bolus 500 milliliters of isotonic saline. Pause here if you want time to think. Going into the answer is B, stop the Milrinone and initiate norepinephrine. So in a patient with renal dysfunction, Milrinone accumulates, right? We talked about how it's renally excreted. So in a patient with renal dysfunction, you may get more hypotension and more arrhythmias as Milrinone accumulates because it's not being urinated out. So the appropriate response in this clinical scenario is to assume Milrinone has accumulated and to stop Milrinone and add a vasopressor, because there will still be Milrinone circulating in that patient for quite some time because they're not able to excrete it okay. So going through the other answers, A, increasing the Milrinone, excuse us, this would just cause more hypotension, more ventricular arrhythmias, and there would be more Milrinone that would be accumulating while the renal function was poor. C, add a beta blocker to suppress the arrhythmia. Adding a beta blocker in this patient's case would actually maybe make them worse because you would be trying to slow down their heart rate and you would be worsening their cardiac output in this patient in cardiogenic shock. So you really want to avoid AV nodal blocking agents in patients in shock. And then bolusing 500 cc's of isotonic saline. This is a patient who is in cardiogenic shock, and giving them more fluid wouldn't be addressing the underlying problem. In fact, it could make them worse depending on if they're already volume overloaded. So stop Milrinone and initiate norepinephrine. What is epinephrine to start? Well, epinephrine is actually also known as adrenaline, depending on where you practice. It actually might primarily be called adrenaline. And this is a potent endogenous catecholamine. And when we're talking about vasopressors, if you've checked out any of our other past vasopressor videos, you'll hear us talk a lot about catecholamine or catecholaminergic or adrenergic. All these are synonyms for vasopressors that work on catecholamine receptors. Things like norepinephrine, epinephrine, phenylephrine. This is in comparison to non-catecholamine-based or non-adrenergic vasopressors, things like vasopressin, angiotensin II, methylene blue, hydroxycobalamin. Again, all different vasopressors we're talking about in this vasopressor series. But there's kind of two different categories. So epinephrine is a catecholamine vasopressor, a catecholaminergic or adrenergic vasopressor. It acts on catecholamine receptors. Particularly two that we talk most about with vasopressors being the alpha and beta adrenergic receptors, which we're going to talk more about. Epinephrine is widely used in shock states, cardiac arrest, and anaphylaxis. It plays a significant role in the management of refractory hypotension in the ICU, and it's definitely one we need to know about. What is interesting about epinephrine, especially compared to norepinephrine, its sister vasopressor, is that epinephrine actually has mixed inotropic and vasopressor properties. Inotropic meaning increasing cardiac output, so affecting the heart more, and vasopressor, which means increasing the mean arterial blood pressure or affecting the blood pressure more. So it has this mixed effect, which we're going to talk more about. And that mixed effect comes from its mechanism of action. So the receptors that epinephrine acts on are, I don't want to say different than norepinephrine, but the ratio and how strongly it affects different receptors is different. So when we talk about the two different receptors, I'm going to draw a blood vessel covered by kind of smooth muscle here. So there's a blood vessel covered by smooth muscle that is coating the blood vessel, and then we'll draw a heart too. Excuse our bad drawings. That's a heart. Right atrium, right ventricle, left atrium, left ventricle. If you're listening to this in podcast form, you're not missing much on these drawings, but you can always hop over to the YouTube video. So epinephrine works on the beta-1 receptor. Beta-1 is a receptor in the heart that increases contractility and increases heart rate. So it has inotropic effects, which is an increase in contractility, and it has chronotropic effects, which is an increase in heart rate. Whereas the blood vessels have alpha-1 receptors, and alpha-1 causes vasoconstriction of the blood vessels in that smooth muscle. So it vasoconstricts. So if we talk about epinephrine in particular, epinephrine has beta-1 effects on the heart, which increases heart rate, that chronotropic effect, increases contractility, that inotropic effect, and both of these lead to increased cardiac output. So this beta-1 effect by epinephrine is this inotropic effect, all right? It also, though, does affect alpha-1 receptors on blood vessels that cause vasoconstriction, increase in systemic vascular resistance, and increase in the mean arterial blood pressure. Epinephrine also has this beta-2 effect on the lungs. We're not going to spend much about it, but it can cause some bronchodilation. This is why you can use epinephrine to treat refractory bronchospasm and asthma. And epinephrine can cause a lactate elevation. So when a patient is getting epinephrine, it most likely will cause a lactate elevation. Now, this elevation, if you have someone on epinephrine and their lactate is going up, you shouldn't just bank on it being because of the epinephrine. You should make sure the lactate isn't increasing for other reasons, but epinephrine does and will cause some degree of lactate elevation. But primarily beta-1 effects and alpha-1 effects. Now, these are dose-dependent, which we're going to talk more about in dosing and administration. So, when it comes to mechanism of action, epinephrine increases the MAP, the mean arterial pressure, through the alpha-1 receptor and increases cardiac output through the beta-1 receptor. But it also can cause hyperlactatemia, It increases myocardial oxygen demand because of that beta-1 effect, making the heart squeeze in over time. And it increases the risk of tachyarrhythmias like atrial fibrillation and SVT because of that beta-1 chronotropic effect. So good things, but also a more robust side effect profile. Again, all things we'll talk more about in the video. So dosing and administration of epinephrine. When it comes, we're going to divide this up into 3 different clinical scenarios. The first one being shock, the second one being cardiac arrest, and the third one being anaphylaxis, because they all require a slightly different approach. So in shock, epinephrine is a continuous infusion. It's weight-based, meaning its units are micrograms per kilogram per minute. Now, some institutions take the kilograms out, and they do non-weight based, all right, just in micrograms per minute. But most institutions, it's in micrograms per kilogram per minute. And you start at 0.01 to 0.05 micrograms per kilogram per minute, all right? And the titration range is then 0.05 to 0.3 micrograms per kilogram per minute that you titrate it to. Now, all this is not a perfect science, right? Some places will titrate to much higher doses of epinephrine than other places. There's probably a peak epinephrine dose that is no longer effective above that dose, but what that is really tough to say. All right. Most places do suggest a central venous catheter to give epinephrine. You probably can give it through peripheral IV if you're doing it in the right way, but only for a limited period of time. And there's really just not a lot of evidence in giving epinephrine peripherally. So more to come on that as evidence evolves. So central line is what's classically recommended here. Now, we do want to point out that different doses of epinephrine have primarily beta-1 effects versus primarily alpha-1 effects. So primarily beta-1 effects, and remember those beta-1 were increasing cardiac output. These are at lower doses of epinephrine. And those lower doses really are somewhere on the spectrum of that initial starting dose, you know, that kind of 0.01 to 0.05 micrograms per kilogram per minute. Primarily have that beta-1 effect. So if you're starting epinephrine just for something like bradycardia, you're really going to just set it at one of these lower doses, 0.01 to 0.05 micrograms per kilogram per minute. You don't want to titrate it up because the beta-1 effect then turns more into an alpha-1 effect, right? And that alpha-1 effect was vasoconstriction. It would just increase the mean arterial pressure. And this is, quote unquote, higher doses, which is really doses just above that initial starting dose. All right, and we'll talk more about this later on in the video too. So for shock, continuous infusion, 0.01, 0.05 micrograms per kilogram per minute. Best done in a central line, although there's some argument there. Cardiac arrest, you usually are giving a 1 milligram IV push every 3 to 5 minutes per ACLS, Advanced Cardiac Life Support protocols, and this is for all types of cardiac arrest. Now, for ventricular dysrhythmias, there's some argument that after a couple doses of epinephrine, giving more might make the heart have a tougher time getting back into sinus rhythm. But again, not great evidence here. So per ACLS, 1 milligram of epinephrine IV push every 3 to 5 minutes. And then anaphylaxis, you're actually giving it IM, intramuscular, right? This is an EpiPen. If people have heard of EpiPens, hopefully you have. It's 0.3 to 0.5 milligrams intramuscular every 5 to 15 minutes. If it is refractory in our practice pattern to 2 doses, we actually start an epi infusion, which is similar to if patients are in shock, that continuous infusion. But you do want to give it intramuscular. Lateral thigh is a common place, 0.3 or 0.5 milligrams every 5 to 15 minutes. And if it's refractory to this, you can change it over to an epinephrine infusion for anaphylactic shock. And again, our practice pattern tends to be 2 intramuscular doses. And if it's still not effective, then we put them on an epinephrine infusion for anaphylactic shock. The pharmacokinetics here are similar to norepinephrine. The onset of action is immediate. It starts working within 1 minute. And then the half-life is only 2 to 3 minutes. So if we think about 5 half-lives, folks say that 5 half-lives is enough for the drug to be pretty much all out of your system. That's just literally several minutes. Somewhere around 10 minutes, the whole drug is gone. So when you stop it, it stops working almost immediately. It is metabolized by the MAO, monoamine oxidase, and COMT enzymes in the liver. So patients with really bad liver function sometimes aren't able to metabolize it as well. And then it's eliminated through the liver and the kidneys, but but with inactive metabolites. Okay, so patients with really bad liver dysfunction, the half-life might be a little bit longer, but not by much, not nearly as much as something like vasopressin. Okay, clinical uses. We kind of talked a little bit about this already. Anaphylaxis is a big one. It's the first-line agent, intramuscular first, followed by intravenous continuous infusion if need be. Cardiac arrest, ACLS algorithm suggests giving it intravenously. Refractory septic shock, it is sometimes given when norepinephrine and vasopressin fail to achieve the target MAP goal. You can consider it. Bradycardia with hypotension might be a nice drug, but remember, this is at those low doses, right? Because you just want that beta 1 effect, somewhere around that 0.01 to 0.05 micrograms per kilogram per minute. And then sometimes post-cardiopulmonary bypass, it's used because it has that inotropic with that beta 1 effect and that vasoconstrictive alpha 1 effect as a vasopressor. What evidence and guidelines do we have on epinephrine? Well, the Surviving Sepsis Campaign recommends epinephrine as a second or third line agent for septic shock after you've already started norepinephrine and vasopressin. It can cause tachycardia, tachydysrhythmias, elevated lactate levels, all reasons that it is not first line in the eyes of the Surviving Sepsis Campaign. ACLS, Advanced Cardiac Life Support, as we talked about, the AHA recommends epinephrine as a cornerstone of cardiac arrest therapy. It improves return of spontaneous circulation, though no consistent survival benefit or neurologic outcome benefit. And this is really interesting if we just go on a little side tangent. In cardiac arrest, epinephrine is like a cornerstone, right? Anybody who's even had a whiff of ACLS training or even basic life-saving training has probably heard of epinephrine. But the data on epinephrine is really old school data. Originally was in like canine models and stuff. And there's not really good evidence to suggest that epinephrine improves our survival or our neurologic outcomes in patients with cardiac arrest. There's actually an old study that looked at escalating doses of epinephrine, starting at 1 milligram and then increasing the dose with each subsequent administration in cardiac arrest. And they got the heart to restart more often, but the neurologic outcomes were way worse. And that's why we don't do it, right? There was no real benefit in long-term survival or functionality. So ACLS, we still are suggesting that you follow ACLS as you should, but it is interesting to think about the evidence behind some of these things we do in cardiac arrest is really, really bad, really, really poor evidence. And we certainly would benefit from more studies on this. It's just a really tough thing to study, right? Comparative studies on epinephrine versus norepinephrine. It seems to have similar MAP effects, but epinephrine can cause more tachycardia, elevated lactate, and potentially some splanchnic ischemia, which is why norepinephrine is our first-line drug as compared to epinephrine. Side effects and complications are similar to a lot of our catecholamine vasopressors. So we already talked about tachyarrhythmias. Because that beta 1 effect of epinephrine, you get more atrial fibrillation, more ventricular ectopy. It also can cause more myocardial ischemia because the beta 1 effect, you're asking that heart to squeeze harder and harder and harder. And while it's doing that, that heart is using more oxygen and it needs more blood flow. So if patients have coronary artery disease, it can increase oxygen demand and cause some degree of myocardial ischemia, like just from a global inability to get enough blood flow to the myocardial tissue. We talked about how it can cause lactic acidosis. Whether that's clinically meaningful or not is tough to say, but the beta 2 receptor effect that it has, remember we didn't focus much on it, but it has beta 2 effect, which can cause bronchodilation, which is why it is sometimes used in refractory bronchospasm and asthma. But that same beta 2 effect stimulates glycolysis, which can lead to elevated lactates. It causes vasoconstriction, so you get the same type of concern for ischemia in the digits or the gut, especially at higher doses. And then beta 2 can also cause hyperglycemia and hypokalemia. Again, not super common things, but it can cause increased lactate, it can cause increased glucose, and it can cause decreased potassium, are the three kind of metabolic things to note for epinephrine. So if we compare epinephrine to norepinephrine, sometimes it's helpful to compare both of these are what type of vasopressors, catecholamine or adrenergic vasopressors, right? These are synonyms, adrenergic and catecholamine. So norepinephrine and epinephrine are catecholamine or adrenergic vasopressors. So epinephrine has beta 1 effects and alpha 1 effects more than these mild beta 2. Beta 2 were for bronchodilation and increasing lactate and increasing glucose and decreasing potassium, whereas the beta 1 is the cardiac effects, alpha 1 is the peripheral vasculature effects. Norepinephrine has alpha and beta 1, but the alpha 1 effects are much greater than the beta 1 effects for norepinephrine. Epinephrine increases heart rate. Norepinephrine maybe mildly increases heart rate, but not by much. Epinephrine increases cardiac output. Norepinephrine maybe mildly increases cardiac output, but not by much. Epinephrine does increase lactate. Norepinephrine does not really increase the lactate. Epinephrine has a higher risk of arrhythmias compared to norepinephrine. And epinephrine is second or third line for septic shock, although it is first line for ACLS and cardiac arrest and anaphylaxis, whereas norepinephrine is first line in septic shock. So just a little comparison between the two. So if we were to summarize epinephrine, epinephrine is a catecholamine vasopressor. It works on beta 1 receptors in the heart, alpha 1 receptors in the blood vessels, and beta 2 receptors in the lungs. Its typical use is first line in ACLS for cardiac arrest, first line in anaphylaxis, and then second or third line in refractory septic shock. The usual infusion dose for something like septic shock that you're starting at 0.01 to 0.05 micrograms per kilogram per minute. In ACLS, the push dose is 1 milligram IV every 3 to 5 minutes. And in anaphylaxis, it is 3, oh goodness, did we blank on the dose? You caught us. It is 0.3 to 0.5 milligrams intramuscular. That you can give every 5 to 15 minutes. Common side effects are tachycardia, right, because it has those beta 1 adrenergic effects, increased lactate, arrhythmias. Other side effects that are not as common are increasing glucose, decreasing potassium, ischemia of the digits or the mesenteria or splanchnic. And then the evidence, there's evidence in ACLS and anaphylaxis, there's mixed evidence in shock, and the evidence in ACLS, as we talked about, you do it, but the evidence is not that strong. All right, that is a summary of epinephrine, part of our vasopressor series. Check out our other vasopressor videos. No further ado, let's dive into Levosimendan, starting with mechanism of action. We do have one other kind of disclaimer on this episode. So Levosimendan is not approved to be used in the United States. So we practice medicine in the United States, which means that we do not use this drug. So everything here should be accurate and good, but we just don't have the clinical exposure to this drug, which means that we cannot speak on some of the intricacies of the day-to-day. All right, mechanism of action of Levosimendan. So this drug's interesting because it's a calcium sensitizer, which makes it an inodilator. Increased contractility but causes vasodilation. So as we mentioned, this enhances myocardial contractility, but it doesn't do so by increasing intracellular calcium. So it does not increase myocardial oxygen demand. It increases the sensitivity of those myocardial heart muscle cells to the calcium already present, which is really interesting. And it does this through 3 key mechanisms. Mechanism 1 is calcium sensitization of troponin C. So troponin C is part of the myocardial contractility apparatus. And when troponin C is more sensitized to calcium, it enhances how hard that myocardial muscle cell can contract. But as the mechanism states, it's not by increasing the amount of calcium there, it's just increasing the sensitization of troponin C to the calcium already present. And troponin C, as we said, is in those myocardial muscle cells. Second part of the mechanism is it opens ATP-sensitive potassium channels in vascular smooth muscles. This is where there's some peripheral vasodilation. So arterial and venous blood vessels have vascular smooth muscle kind of coating the outside. And that vascular smooth muscle helps that vein or artery contract or dilate. In the vascular smooth muscle, there's these potassium channels. And Levosimendan opens more of these potassium channels, and by doing so, the smooth muscle relaxes, and it can cause arterial and venous vasodilation. It does a similar thing in cardiac myocytes, right, the muscle cells, and some folks think this might be cardioprotective to a degree, anti-stunning, anti-apoptotic, anti-inflammatory, although we don't really know that for sure. So as we mentioned, the mechanisms here, calcium sensitization of troponin C in the myocardial cells, opening of ATP-sensitive potassium channels in vascular smooth muscles, and possibly opening mitochondrial ATP channels in cardiac myocytes. This will increase contractility, and it will decrease systemic vascular resistance. So those are kind of the two big things that we're going to be talking about. Some people kind of say it has more squeeze for less of the cost because it's not increasing myocardial oxygen demand. So it increases inotropy or contractility with lower risk of myocardial ischemia compared to catecholamine-based inotropes. So dosing and pharmacokinetics. The loading dose of levosimendan is optional, not often given, but it'd be 6 to 12 micrograms per kilogram IV over 10 minutes. But the maintenance dose, the infusion dose, which is more common, is 0.05 to 0.2 micrograms per kilogram per minute. And the onset of action is within 30 to 60 minutes, so it's not immediate. You have to be patient because it takes a little while to kick in. The half-life of the active metabolite is very long, 80 hours, this active metabolite, OR1896. So this is a super long half-life for an inotrope or vasopressor, and this drug then sticks around for a long time even after you stop it. It's something to be aware of. So the duration of effect can last 7 to 10 days after 24 hours of infusion. 7 to 10 days this drug can be active in your body, causing its effect. So you better hope you wanted it there, because it's going to stick around for a while. This is very atypical for vasopressors and inotropes. Usually it's on the order of minutes, let alone hours or days. It's metabolized in the liver hepatically, so if you have severe liver dysfunction, you might actually not metabolize it as fast, and it's already metabolized really slow, so you could have more buildup. And then it's excreted in the urine, but its metabolites are excreted in the urine, so it's already broken down into its non-functional metabolites before it's excreted in the urine. Loading dose that we said is optional and not usually given can cause hypotension, which is why it's usually not given in unstable patients. Indications. In Europe, in South America, and in Asia, this is an approved medication for acute decompensated heart failure or cardiogenic shock, but it is not approved in the United States of America. The reasons as to why are probably more complex, but a lot of the resources that we read said things like, not enough evidence, possible worse long-term cardiac outcomes. But again, we don't use it, so it's hard for us to comment on all the intricacies of that. But in Europe, South America, and Asia, it is approved for cardiogenic shock and acute decompensated heart failure and other low cardiac output states. It's being investigated for right ventricular failure, septic cardiomyopathy, cardiorenal syndrome, bridge to transplant. These are all similar things to above cardiogenic shock and acute decompensated heart failure. But as we mentioned, it is not FDA approved in the United States of America, although it is available in 50 other countries, more than 50 other countries. All right, adverse effects. Well, we said that it can cause vascular smooth muscle relaxation and vasodilation, which can lead to hypotension. So vasodilation causing hypotension is adverse effect. It can cause headaches. The vasodilation can sometimes cause these reflexive headaches. It can cause arrhythmias, although less than dobutamine, which is another inotrope that we've talked about in this series. It can cause hypokalemia secondary to that potassium channel modulation. Remember, we said it opens ATP-sensitive potassium channels, both in vascular smooth muscle as well as some mitochondria and cardiac myocytes, and that can lead to hypokalemia. And rarely, it can cause thrombocytopenia or low platelets. The hemodynamic profile here is related to the mechanism we talked about. So for systemic vascular resistance and mean arterial pressure, remember we said it causes vasodilation, so it's going to cause a decrease in systemic vascular resistance, which will then lead to a decrease in mean arterial pressure. It does not tend to affect heart rate. It does not tend to cause the heart rate to go up. It can sometimes mildly, but not to a large degree. It does increase contractility with little O2 cost, right? Because we said it does not increase myocardial oxygen demand that much, which is very different than a lot of our inotropes we have out there. Dobutamine, Milrinone, Epinephrine, all those can increase myocardial oxygen demand, but Levosimendan theoretically does not. So increasing cardiac contractility increases cardiac output, and it can decrease pulmonary pressures too, pulmonary vascular resistance, so it could be beneficial in RV failure or pulmonary hypertension. All right, some of the trials out here, there's a lot listed here, and we're not going to go through too many of them, but we will just give a couple highlights. Again, we don't use this in the USA, so I'm not as plugged into all these trials, so take some of this with a grain of salt, but we'll give you some highlights here. There's a trial in 2022 called the LIDO trial, published in The Lancet, compared to Levosimendan versus Dobutamine in acute decompensated heart failure. Levosimendan improved cardiac output and had a lower 31-day mortality. There's the SURVIVE trial in 2005 in JAMA. It's a large RCT, randomized controlled trial of Levosimendan versus Dobutamine. There's no difference in all-cause mortality here, but possibly a benefit in patients on beta blocker use. This is not atypical, right? Dobutamine, as we've talked about in the Dobutamine episode, affects beta-1 receptors. So if you're on a beta blocker and your beta-1 receptors are blocked, Dobutamine won't really be able to work well. So it's not it's not a surprise that Levosimendan may have been better in patients on Dobutamine. All right, this is why patients on beta blockers instead of Dobutamine in the US, we tend to use Milrinone, because Milrinone works on phosphodiesterase 3 receptors. The REVIVE 1 and 2 trials published in 2006 in JACC, Levosimendan versus placebo in acute heart failure. It improved symptoms, but there was more hypotension and arrhythmias in Levosimendan group. The Levo CTS trial published in 2017 in the New England Journal of Medicine. This was in cardiac surgery patients. No difference in death, renal replacement therapy, mechanical circulatory support, but it may reduce low cardiac output syndrome post-op in selected patients. Meta-analyses through the years, it may reduce renal dysfunction, it may improve inotrope requirement, and it may improve weaning failure from mechanical circulatory support, but there's been no consistent mortality benefit. Potential signal of benefit in cardiac surgery patients and patients with right ventricular failure. So that's some of the evidence out there. If we were to summarize this into the clinical pearls, this is a unique drug among inotropes. It does not increase intracellular calcium and as such does not increase your myocardial oxygen demand. It just increases your sensitivity to the calcium present. It persists for days after discontinuation due to this long-acting metabolite, right? 7 to 10 days. Consider use when patients have a tachyarrhythmia or are beta blocked, if you're in one of the countries that can use them. It may be more useful in RV failure because it might decrease your pulmonary vascular resistance. That's what your right ventricle pumps against, the pulmonary vascular resistance. May be more useful in post-cardiac surgery patients or patients with pulmonary hypertension, but who knows. Summary drug class, this is a calcium sensitizer, and it also is a potassium ATP opener. It is not FDA approved in the US, although it is approved in more than 50 other countries. It takes about an hour for it to kick in, and it can last in your system for about 7 to 10 days, right? Very long half-life. Its primary effects are increasing contractility, increasing cardiac output, and decreasing systemic vascular resistance, and decreasing the mean arterial blood pressure. Adverse effects related to this, hypotension, hypokalemia, and arrhythmia are all on there. All right, should we dive into some practice questions? There's 3 of them, 1 beginner, 1 intermediate, and 1 advanced. As always, if you've seen our episodes before, we will read the question, read the multiple choice answers. We'll then give you a chance to pause the video and then dive right into the answer. So if you need more time to think, just pause the video there. All right, beginner level question. What is the primary advantage of Levosimendan over traditional inotropes like Dobutamine? A, it increases contractility without increasing oxygen demand. B, it has no vasodilatory effects. C, it is safer in severe hypotension. Or D, it has no active metabolites. All right, pause here if you need more time. The answer is A, it increases contractility without increasing oxygen demand. As we mentioned, Levosimendan sensitizes troponin C in the myocardial cells to calcium without increasing intracellular calcium amounts. Thus, it increases inotropy without increasing myocardial oxygen demand. Other options in this question. B, it has no vasodilatory effects. We know that it actually does cause vasodilation, so that is not true. It is safe in severe hypotension, again, causes vasodilation, so that is not true, and it has no active metabolites. We said the active metabolite actually lasts in the system for 7 to 10 days, so you know that is not true as well. All right, intermediate level question. Which of the following mechanisms explains levosimendan's ability to reduce pulmonary artery pressures? A. Beta-2 stimulation. B. Phosphodiesterase 3 inhibition. C. Opening mitochondrial potassium ATP channels. Or D. Smooth muscle vasodilation via potassium ATP channels. Pause here if you need more time. The answer is D. Smooth muscle vasodilation via potassium ATP channels. So levosimendan, as we talked about, causes vasodilation of the blood vessels by activating this ATP potassium sensitive channel in vascular smooth muscle. This reduces both systemic and pulmonary vascular resistance and explains why it could reduce pulmonary artery pressures. What are the other options here? A was beta-2 stimulation. Levosimendan does not have beta-2 effects. Some of our adrenergic vasopressors have some beta-2 effects. Dobutamine is the inotrope that does have beta-2 effects, leading to some vasodilation. Option B was PDE3, phosphodiesterase 3 inhibition. This is the mechanism of Milrinone. And then option C was opening mitochondrial potassium ATP channels. Levosimendan does do this, but it just doesn't answer the question. All right, last but not least, advanced level. A 67-year-old patient with ischemic cardiomyopathy and ejection fraction of 20% is on metoprolol and develops acute decompensated heart failure in one of the countries in which levosimendan can be used. Which inotrope is most favorable and why? A. Dobutamine due to quick titration and short half-life. B. Dopamine due to beta-1 effect and MAP support. C. Levosimendan as its effects are independent of beta receptor stimulation. D. Milrinone due to its PDE3 inhibition and rapid onset. Pause here if you need more time. The correct answer is C. As one could imagine, levosimendan as its effects are independent of beta receptor stimulation. Remember, there's a calcium sensitizer. It does not work through sensitizer. We couldn't spell for a sec. It does not work through the catecholaminergic or adrenergic receptors like beta receptors. So in patients on chronic beta blocker therapy, catecholamine-based inotropes like dobutamine and dopamine are less effective. Levosimendan enhances contractility through calcium sensitization and is unaffected by beta receptor blockade. Milrinone actually would be a reasonable choice as well, which we put it in there just so you'd think more about it. But this explains the other options. Dobutamine. Dobutamine uses beta receptors, so it would not be a good choice in patients on beta blocker therapy. Dopamine does the same thing, and we don't really use dopamine anyways. And then Milrinone is actually a reasonable choice in the US. This is the choice we use in patients on chronic beta blockers because we don't have access to levosimendan. Dopamine. So starting with mechanism of action, how does dopamine work? Well, dopamine is a dose-dependent adrenergic and dopaminergic agonist. Lots of big words here. So dose dependent, that one's obvious. Different doses cause different things to happen. We'll talk about that. Adrenergic. This is something we've talked about in previous episodes on vasopressors. And adrenergic means catecholamine based. The mechanism of action uses catecholamine receptors, right? These are things like norepinephrine, epinephrine, phenylephrine, and now dopamine as well. And then dopaminergic, it acts on dopamine receptors as well. An agonist means it stimulates said receptors. So it is a dose-dependent adrenergic and dopaminergic agonist. So going into its mechanism of action a little bit more, there's some dose-dependent nature to this, right? We kind of talked about that a little bit. And these doses are in micrograms per kilogram per minute. In 0.5 to 2 micrograms per kilogram per minute, tends to act on dopaminergic receptors, D1 and D2. These are primarily in the kidneys. And it causes some renal-based vasodilation and theoretically increased urine output. You know, back in the day, there was this idea that dopamine is renal protective. You can use it for kind of renally dosed dopamine to protect the kidneys or improve renal function, but this isn't really supported by evidence any longer. So this renal dosed dopamine certainly isn't used, or I guess we should rephrase, there's no evidence or guidelines to recommend its use in this fashion. All right, so that's 0.5 to 2 micrograms per kilogram per minute. A little bit above that is 2 to 10 micrograms per kilogram per minute. And this is where it starts to act more on beta-1 receptors. As we've talked about in previous episodes, beta-1 receptors act on the heart, right? So the heart has beta-1 receptors, whereas alpha-1 receptors act on the blood vessels, which we'll get into. So at 2 to 10 micrograms per kilogram per minute, it primarily affects beta-1 receptors. It still has some dopamine D1 and D2 receptor effects. But the beta-1 receptors being in the heart do increase heart rate and increase contractility, which then increase cardiac output. Okay, and that is true, right? At these 2 to 10 micrograms per kilogram per minute doses, it affects beta-1 receptors more than the dopaminergic D1 and D2 receptors. And these beta-1 receptors in the heart increase heart rate, increase contractility, increase cardiac output. As we continue going up on doses to more than 10 micrograms per kilogram per minute, you start to get more alpha-1 receptor effects over beta-1. You no longer are getting those dopamine receptor effects. So more than 10 micrograms per kilogram per minute of dopamine, you get primarily alpha-1 effects with a minority or a lower amount of beta-1 effects. So this is when alpha-1 on the blood vessels leads to vasoconstriction that increases your systemic vascular resistance, which then increases your blood pressure, your MAP, through vasoconstriction. It still has a little bit of the cardiac beta-1 effects, increasing heart rate, contractility, and cardiac output, but it primarily increases your blood pressure at these higher doses. And this will be important when we talk about indications, because there's going to be some dose-dependent indications here as well. So dosing and pharmacokinetics. Typical dosing range, although this is more theoretical, people use all sorts of different doses, but is 2 to 20 micrograms per kilogram per minute. We talked about how that 0.5 to 2 was the old school kind of renal dosing that works on dopamine receptors in the kidneys. That is no longer a thing. So 2 to 20 micrograms per kilogram per minute, with the first 2 to 10 primarily being beta-1 receptor effects, and then greater than 10 being primarily alpha-1, at least more than beta-1 receptor effects. Onset is 5 minutes, half-life's 2 minutes, so it's fast on, fast off. Now, fast on does not mean instantaneous, right? It takes about 5 minutes to kick in. So if you were to start something like dopamine, you have to wait a little bit before we see its full effect. Just like norepinephrine is about 2 minutes. If you start norepinephrine and you give it 10 seconds and then you start increasing it and increasing it, you won't really see what that dose did, and you'll probably end up causing some hypertension because you probably up-titrated doses too quick. So onset of action for dopamine is 5 minutes, half-life's 2 minutes. It is metabolized hepatically as well as renally, so in the liver and kidneys through the MAO and COMT mechanism. So if you have significant liver or kidney dysfunction, this can lead to longer half-lives because you won't be able to metabolize it as fast, and it's excreted in the urine. But the metabolites are excreted in the urine, right? It was already metabolized to its inactive metabolites that are then peed out. Duration is short, duration of action, so you need a continuous infusion. This is a continuous IV infusion of dopamine. You're not bolusing it or, giving it PRN. It's continuous infusion. You usually titrate it based on your hemodynamic goals, often guided by cardiac output, blood pressure, perfusion indices, if you're going to use it, which is a big if, which we'll talk more about. So indications. In the ICU, our humble opinion, which is just our opinion, we pretty much never use dopamine. I can't think of the last time I used it in the clinical arena. There's one small exception where, in our humble opinion, it's still reasonable, and that's the bradycardic patient at those low doses, those 2 to 10 microgram per kilogram per minute doses. Dopamine is reasonable to use because at this dose, it's primarily beta-1 effects, which will increase your heart rate. Now, epinephrine is just as good, so we tend to use epinephrine, but dopamine, it's reasonable to use for bradycardia with hypotension. Some people still use it in cardiogenic shock, right, at those 2 to 10 microgram per kilogram per minute doses, primarily affecting beta-1 receptors, although we don't tend to do that. Historically, it was used in septic shock, but this is not really done anymore. Evidence would suggest that this is a worse option than norepinephrine, so you should just use norepinephrine, not dopamine in septic shock. And then symptomatic hypotension, this isn't really a thing anymore either. So this is not commonly used, with the one caveat being, and although we don't do it because we would just use epinephrine, that you could consider using it for bradycardia at those lower doses. Contraindications and cautions: you should be careful in patients with pheochromocytoma because of the alpha-1 effects. Allergy to sulfites. Some formulations of dopamine have sulfites in them. And then dopamine is really bad for causing tachyarrhythmias, so you got to be really careful with that. It can cause ischemia of the mesenteric digits, just like many vasopressors, especially if a patient has severe hypovolemia. It can really then lead to worsening ischemia, so make sure you're volume replete if you were to use this for some reason. Adverse effects, as we talked about: tachycardia given the beta-1 stimulation, and arrhythmias, particularly ventricular arrhythmias, are a big thing. Arrhythmias are one of the reasons that we choose norepinephrine over dopamine in many of these cases. It can cause myocardial ischemia, which any drug that is going to have beta-1 receptor action that then increases contractility, it can have some worsening myocardial ischemia because you're asking that heart muscle to squeeze harder, and when it squeezes harder, it uses up more oxygen. So that's not particular to dopamine. If dopamine is going through a peripheral IV and it extravasates, it gets out of the IV into the subcutaneous tissue, you can get extravasation injury through its alpha-1 mediated vasoconstriction, common of many vasopressors, which is why most of the times we're putting these through central lines, although there is some blossoming evidence on the safety of peripheral vasopressors, particularly norepinephrine. That is in a different episode, though. Nausea and headache. Dopamine can cause nausea and headache through CMS stimulatory effects. Reduced GI perfusion. It vasoconstricts the splanchnic circulation, the circulation around the bowels, that can cause reduced GI perfusion, which can lead to mesenteric ischemia. Again, many vasopressors, norepinephrine and vasopressin, do this too, although dopamine is definitely a culprit. If you get extravasation injury, you treat that with phentolamine. Just a little shout out to that, although we're not going to go too much more into that. Hemodynamic profile. What are the actual hemodynamic effects of dopamine? Remember, this is dose dependent. That's the whole story here with dopamine, dose dependent. So at higher doses, that greater than 10 micrograms per kilogram per minute, it primarily has alpha-1 effects that increase SVR, systemic vascular resistance, and increase the MAP, the mean arterial pressure. At those medium doses, 2 to 10 micrograms per kilogram per minute, it primarily has beta-1 effects, which are going to increase heart rate and increase contractility. At those low doses that we don't recommend anymore, 0.5 to 2 micrograms per kilogram per minute, there's that theoretical increase in renal perfusion, but that is not a real thing. It's not clinically supportive anymore. So hemodynamically, increase SVR and increase MAP at higher doses, increase heart rate and contractility at lower doses. The studies that have helped inform our use of dopamine. One is the SOAP2 trial in the New England Journal of Medicine in 2010 that compared dopamine versus norepinephrine. And the dopamine group had more arrhythmias, and there was no mortality benefit with dopamine. So norepinephrine was preferred over dopamine in most shock states because there's less arrhythmias. The renally dosed dopamine, there's a meta-analysis in the 2000s that showed no benefit of low-dose dopamine in preventing acute kidney injury. That's why it's not recommended anymore. There's a dopamine versus epinephrine and neonatal shock trial published in the New England Journal of Medicine in 2011. Dopamine was associated with lower mortality compared to epinephrine and septic shock, but this is specific to pediatrics and not generalizable to adults. We don't take care of pediatric patients, so we don't know all the details of that, so we're going to cross it out, and you'll have to do more research on that yourself. When we get to clinical pearls on dopamine, dopamine is not favored to be used in ICU practice. It is more arrhythmogenic. It can cause ischemia. It is not recommended in septic shock. You could consider dopamine at lower doses, 2 to 10 micrograms per kilogram per minute, in symptomatic bradycardia with low MAPs, just as a bridge to whatever you're going to do to fix that heart rate. That's not unreasonable, although we usually use epinephrine instead. If you are using dopamine, watch out for peripheral ischemia, and central access is key, especially at moderate to high doses, because extravasation can be limb-threatening. So in summary, dopamine is an endogenous catecholamine. It primarily works on catecholamine receptors, beta 1 at 2 to 10 micrograms per kilogram per minute, and alpha 1 at doses higher than 10 micrograms per kilogram per minute. The onset of action is about 5 minutes, so you need to give it a couple minutes before you see its effect. Typical dose is 2 to 20 micrograms per kilogram per minute. The arrhythmia risk is very high, and this whole idea that it helps renal perfusion is not clinically borne out in trials. Some practice questions, 3 of them, starting with beginner. We'll do the practice questions as we always do. I'll read the question and the answers. I'll say quickly, pause if you need more time, and then I'll go into the actual answer. So if you need more time, make sure to pause it because we'll go right into the answer. Beginner question level number 1. Beginner level question number 1. That makes more sense. Which of the following best describes the receptor effects of dopamine at doses between 2 and 10 micrograms per kilogram per minute? A, pure alpha-1 stimulation. B, pure beta-2 stimulation. C, predominantly beta-1 stimulation. Or D, predominantly dopaminergic stimulation. Pause here if you need more time. The answer is C, predominantly beta-1 stimulation. So at this range, dopamine increases inotropy and heart rate via beta-1. Right? Pure alpha-1 stimulation tends to be greater than 10 micrograms per kilogram per minute. It does not cause beta-2 stimulation, and then predominantly dopaminergic stimulation is that 0.5 to 2 micrograms per kilogram per minute, although there's no reason to use it at these doses anymore because it is not shown to be renal protective. All right, intermediate level question. Which of the following is a major reason dopamine is no longer preferred as first-line vasopressor in septic shock? A, it causes hyperkalemia. B, it lacks any beta-adrenergic activity. C, it has a higher risk of arrhythmias. And D, it improves renal perfusion too strongly. All right, pause here if you need more time. The answer is C. It has higher risk of arrhythmias. Remember that SOAP-2 trial published in the New England Journal of Medicine showed that there was more arrhythmias and adverse effects with dopamine as compared to norepinephrine, which is why we use norepinephrine for these patients. It does not cause hyperkalemia. It does have beta-adrenergic activity, right? Those doses between 2 and 10 micrograms per kilogram per minute are primarily beta-1 effects. And then it improves renal perfusion too strongly is just a ridiculous answer. But even the whole thought that dopamine can improve renal perfusion is no longer borne out as true. Last question, the advanced level. A patient in cardiogenic shock has a MAP of 68 millimeters of mercury and a heart rate of 48 beats per minute. You are considering dopamine versus norepinephrine. What factor might favor dopamine in this case? A, risk of renal injury. B, need for alpha-1 mediated vasoconstriction. C, coexisting bradycardia. Or D, risk of tachyarrhythmias. Pause here if you need more time. The answer is C, coexisting bradycardia. So the one time in which we say you could consider dopamine, although we do not do this in our practice, is bradycardia. Dopamine may increase heart rate in patients with bradycardia, making it temporarily helpful, potentially, as a chronotrope or a drug to increase heart rate. None of the other answers useful, and even this for us, we do not do this, but we at least wanted to put something in there for how you could potentially consider using dopamine. That's all.